Good evening, everyone. Welcome to the 2020 Lehigh Valley Pediatric Epilepsy Conference. Glad you can join us here this evening, and also welcome to those that are joining us online via Zoom. Glad to see you this evening. So if you're joining us virtually, your audio and visual will be muted for the entirety of the conference. You'll have the opportunity to ask questions on the chat box at the bottom of your screen. And you can ask those questions to Rena, who's manning the Zoom tonight, and then she or I will ask the doctor or Sarah afterwards. I'm stumbling. Afterwards, the questions. So just to let you know, you're not alone in your diagnosis of epilepsy. Almost 3.5 million people in the United States alone have epilepsy. 6 out of 10 people, the cause is unknown. A third of people with epilepsy, it's not being controlled with medication. And the number of people that will have epilepsy develop it in their lifetime is 1 in 26. So it's common, you're not alone, and we're here for you to help you connect with other people with epilepsy. So the Epilepsy Foundation Eastern Pennsylvania serves the 18 counties of Eastern Pennsylvania. We're focused on education, support, and advocacy, and we've been around for you guys for the last 50 years. This is our 50th anniversary this year. Yay. Some of our programs and services we're very proud of. We have seizure recognition and first aid trainings for teachers, first responders, EMS, police. We even go out to schools. We go out to schools, and we also go to businesses. So anybody that will listen to us, we'll talk to. We have monthly support group meetings all throughout the 18 counties. So there's a lot to choose from there. Advocacy efforts, we go to Harrisburg and advocate for the foundation and for funding so that we can continue to do the programs and services that we provide. We have community and awareness events throughout the year. Educational conferences like the one we have here tonight. Information and referrals. Someone with epilepsy is looking for some sort of help in the community. We can help them track down some resources for them, either themselves or their children of any age. And we have lots of retreats and camps. Coming up is Camp Achieve, August 14th through the 19th. It's a week-long sleepaway camp tailored for people with children with a primary diagnosis of epilepsy from ages 8 to 17. And it's a great opportunity for children to get together with other children that have epilepsy and make really lifelong friendships. And they get to see that they're not alone in their diagnosis, that there's other people that they can make friends with. It's just, we're very proud of it. 2 programs that we have, I just want you to make you aware because they're relatively new, is the Hopscotch program. It stands for Home-Based Self-Management and Cognitive Training, Changes Lives. And this program is designed to help people with epilepsy find ways to manage and cope with the memory problems that are often associated with it. And then the PACES program is a program of active consumer engagement in self-management. And that's a program designed to increase the medical, psychological, and community adjustment, and community adjustment of adults with epilepsy. So I wanted to make you aware of those 2 relatively new programs that we've introduced. So how can you get involved? The key is to raise awareness and share your story. But you can volunteer, be an advocate. You can invite the EFEPA to come into a school, workplace, church, wherever it is, so we can talk about epilepsy and seizure recognition. You can come to one of our events. You can follow us on social media. And so there's our Facebook, Epilepsy Foundation Eastern Pennsylvania, and Instagram and Twitter at EFEPA. So we're not hard to find. So we talk about like how you can volunteer or get involved. November is Epilepsy Awareness Month. And that's a week-long chance to tell the community and your loved ones about epilepsy. Raise awareness, inspire action, and create change. Wear purple. That's why I'm wearing purple. Purple is for epilepsy awareness. So you can go to our website and see how you can be involved this November. Just, you know, some people like on Facebook, they'll maybe put a fact a day in November, like those facts that I told you. Did you know? And that raises awareness. We have someone who likes to do physical exercise based on like maybe 26 push-ups for the 1 in 26. So it's a great way to raise awareness just on social media, because we all know that it's traditionally been the topic that no one talks about. You know, that it's, I don't know how many stories I hear about an adult that says, we never talked about it in my family, my mother never said anything. So we want to take that out of the shadow. So if you can just post a few things in November, that's practically volunteering for us. So we really appreciate that. So coming up June 12th is the Walk to End Epilepsy Lehigh Valley, and it's literally right down the street at Upper Saucon Township Community Park. We're back with our potluck lunch. So in the pavilion afterwards, people get to meet other people with epilepsy and families and connect. So we're really excited about that. So head over to our website. It's actually epilepsywalklv.org if you want to sign up. We're really excited about that. We have a young adult retreat May 13th through the 15th. That's at Camp Green Lane. What's the ages for that? 30 and over? 18 to 30. So we've been introducing all these programs for young adults, for adults, for children. You know, we're trying to cover all the bases so everyone can feel like they're involved. So just head over to our website. It's really easy to find all our upcoming programs. I have a support group every second Thursday of the month, but because of Zoom, a lot of people can tune into various support groups throughout. Like some people from the Lehigh Valley will go to the Philadelphia one, you know, via Zoom. So we have lots of those, and often we have speakers, so you can check that out. So I want to thank our conference series sponsors. If you haven't gotten a chance, they're all out there in the lobby. Special thank you to Marinus and UCB Pharma. And a special thank you to our vendor sponsors, Aquestive and Jazz Pharmaceuticals. So if you get a chance, there's some really neat stuff they have to share. Go and speak to them. So tonight, we're starting a little late, but we're gonna first start out with the doctor-patient relationship. Then we're gonna have a little break, and then we're gonna do epilepsy and genetics. So that's the way it's gonna go. So my first speaker, I've been trying to pronounce her name all night. Here we go. Akila Venkataraman. She is a pediatric neurology at Geisinger Medical Center. So while the science of neurology and development inspires her, interacting and building relationships with her patients and their families is really what she really loves to do the best. She has over 20 years experience, and her goal is not only to treat her patients' medical conditions, but to understand and improve social conditions that impact health and illness. She's an advocate for improving awareness and education about epilepsy. In her spare time, she enjoys learning new languages, new cultures, exploring new places, and trying new foods. She also enjoys mentoring children and spends a lot of time volunteering for local and international organizations. Please welcome Dr. V. I did it. That's so funny. Oh no, I can't get this off. I had this problem before. All right, thank you.
Thank you. Thank you, Ellen, and good evening, everyone. Thank you for coming out and coming online. They couldn't have picked a better topic for me. This is my philosophy in life. You know, it's about the doctor-patient relationship. What is this? What is a doctor-patient relationship? And why is it important? Why am I standing here having driven all this while to come talk to you about this, right? This is basically, we're talking about a team, right? We're talking about people who are involved in that team to make miracles happen, right? Now, who are the players in this team? Well, obviously, the most important one is the actual patient, because if there wasn't a patient, there would be no need for the doctor, no need for this relationship to happen, right? Not only are they the crux of that relationship, they are also the ones that whoever else is in the team is going to be looking to take care of, okay? And that's great, but that's one part of the team. And interestingly enough, in my field, in pediatric neurology and pediatric epilepsy, it's not just a simple doctor-patient relationship, is it? There are a lot of moving parts. We come with a posse, each one of us, right? So the patient has the symptoms, has the seizures, and will be the one taking the medication. But a lot of times, that's pretty much all that they're a part of that relationship, right? It's the caregiver, it is the parent, the guardian, the one who is actually, probably the most important part of that team in between the doctor and the patient, right? Because the caregiver, the parent, is the one who's either going to be administering the medication, is going to be bringing the patient to the doctor in the first place, right? Having to administer the medication, witness seizures, see what side effects, how they're responding. And guess what? They're also the only person that the doctor can get their information from in that situation, right? So it's really patient, caregiver, doctor relationship, right? Now, again, just like I mentioned, it's not just simple, these three people. It's a very complex network of people. So on the doctor's side, sure, I might be the face of the doctor part of this relationship, but guess what? I have staff, I have nurses, I have schedulers, I have, then there's insurance people, then there's pharmacists, there's so much more. So when we say doctor, we're talking about the medical side of it, right? So we start thinking, oh, well, it's just a relationship between two people. Yeah, I got to like the doctor and whatever. No, it takes a lot more than that. Okay. So this, I thought a lot about this slide. And so I can speak obviously from the doctor's perspective. What would make that doctor-patient relationship ideal at an appointment, right? So I can speak on behalf of the doctor's side. What should we expect from a doctor at an appointment? Okay, so when I speak from the doctor's standpoint, I think as a patient, you should expect honest and complete information, right? So I should be clear. I should be able to, if I do not know the extent of the diagnosis or what exactly is going on, at least I should be able to communicate that clearly to you. What I think it is, how I think it's happening, why I think it's happening, and what we can do about it, right? And it has to be upfront and honest and complete, at least to our own knowledge. So typically when I see a patient, whether it's the first time or the 10th time, when I'm talking to the parent, I pretty much tell them everything I know about it, okay? I will sit there and give them a lecture on EEGs, okay? I will tell you, my patient parents can probably come work as EEG techs for me, okay? With me, rather, okay? So, and I feel like knowledge is power, right? So the more I inform them, guess what? They're going to be able to give me information with that in mind. So guess what? It makes my job easier, right? Now, it's one thing for the doctor to give you information, tell you, and again, I can talk. So, there are people here that can vouch for that. But it's not just about me talking, okay? The doctor has to listen, okay? Not just hear and listen, okay? And process that. So for example, you have to understand, as a doctor, I tell you, take XYZ medication, right? You're gonna take this pill and and you're gonna take it this way, this way, this way, right? And I'm expecting that your seizures are gonna stop and your EEG is gonna look great, okay? That's what our medical training makes me talk like, right? And then I have a mom who's telling me, yeah, first of all, my kid just spits the medicine back at me, okay? That's when I can even find the time to give the patient the medicine. The pharmacy, gyps me of my script, I only got 20 days worth. I didn't get the last 10 days, right? I don't know. I can't tell you exactly how it's affecting my child, but my child's different. And I don't think this is the medicine for them. I see a lot of nods, right? And so here's the thing. We need to listen. I need to listen. Medicine needs to listen, okay? So that's really important. And that's part of this relationship. I need to ask questions. The doctor needs to ask questions, okay? But it's not just the medical questions, okay? It's the life questions. What is your daily life like? Okay. For example, again, I go back, I'm writing, oh, let me do that. Where's your pharmacy? All right, let me give you 3 months supply. Okay. Did I ask if the kid can swallow pills? Did I ask what time they have to get up and get to the bus to go to school? Did I ask whether they have breakfast at home or in school? If I'm telling them to take the pill after breakfast, I need to ask, right? So those are the kind of questions that we need to ask. And I'm talking on behalf of the doctors, right? I need to make sure, again, I'm talking, right? And right now, yes, thankfully I'm seeing some nods, which I'm assuming is understanding and, agreement. But again, if I'm so gung-ho about explaining EEGs and, neural circuits and stuff, and, the parent is just staring at me going, all right, just give me some pills, I'll be fine, just tell me what to do, then that isn't appropriate either, right? So I have to confirm that they understand what I'm trying to tell them, the information that I'm trying to give them. So communication, right? Communicate. Look, you have the word relationship, guess what? You're gonna have to have the word communication, right? Now let's flip it over to the patient side, okay? I've been a patient, right? Hopefully a good one. But they say, right, doctors make the worst patients. I try. But again, for the doctor, what do we need to be able to say, okay, I can treat you well. I can, take care of you as you need to be taken care of. What do I need? I need honest, I need complete information. Okay? If you're not taking your medicine, you've forgotten it. Okay? Guess what? I can be writing the best medication in the world and imagining it to work. Guess what? It's not going to work. Okay? And I'm going to go crying home. Oh my God, nothing's working. You know, I don't think that's fair to me, right? So, look, it can only work if we're both on the same page. Okay? And for that, each one of us needs full and honest information. Right? So, listen. Okay? Yes. I mean, you know, in this day and age, I have tons of people who come into my office, right, with their agenda, their ideas, their thoughts. Okay, I'm coming to you. I'm also a general neurologist. And so, oh, yeah, we're here because, you know, my son little Johnny needs an MRI. I'm like, okay, why? You know, they've done their whatever, their Google search, and they have an idea that an MRI is the answer to all their ills. You know, maybe sometimes if you're coming to me for my expertise, maybe listen to what I have to say, you know? But also ask questions. Last September, I was at the Adult Epilepsy Wellness Weekend. I will tell you, it was an eye-opener for me, okay? It was the best weekend I've had. But it was amazing because I got to hear the patient side of things, right? What they find be the most difficult part about navigating this whole, you know, epilepsy care, right? How do you talk to your doctor? What do you tell your doctor? Right? And it was so surprising to me that half of the people I spoke to don't actually really interact that much with their doctor. They don't ask the questions, okay? They don't tell them stuff, right? Now, again, I can't speak for all doctors, nor can I speak for all patients. You know, it takes all kinds. But here's the thing. I mean, I am a neurologist, but I do not read minds. Okay? I've been waiting to use that line. But that's the thing, right? If you don't tell me, how am I going to know to even ask about it? Okay? Look, I'm not there to witness seizures. I have to literally go by what you tell me. So if you don't tell me, I don't know. How am I going to treat something I don't know about? Right? If you don't tell the doctor, look, this pill is causing me memory issues. Oh my God, I was so surprised how many people were complaining about that, right? And all it would have, so I asked, have you talked to your doctor about it? Well, not really. Okay, and I'll tell you where that problem comes about. I for sure, and this I'll probably speak on behalf of most neurologists and certainly pediatric neurologists, we don't go into this for the fun of it, okay? We are passionate about this, okay? It's not like you just woke up one day and go, I think I'll be a pediatric neurologist. I'll do years and years of study, be on call, and no, that's not how it works. So we really like what we do, and we really want to make a difference, okay? The problem is the system is set up where, you know, unfortunately, appointments end up being, especially follow-up appointments, are what, 15 minutes, 20 minutes, okay? And that you have to actually come in, get your vitals, get it, you know, change or do whatever, find the damn room that's open and come in, sit down, and then I need to come in. I have to figure out how to start the computer. All I'm busy is documenting. It's nonsense, right? How much can I establish a relationship in that? And what happens in that appointment? How many seizures have you had since I last saw you? Are you taking your pills? What is your dose? where's your pharmacy? Okay, let me send you, when was your last EEG? What were your levels? Ding, next, right? And it's not our fault, it's not your fault. It's the way the system is set up, right? And especially in pediatric neurology, pediatric epilepsy, we need time, okay? I love to coddle my patients, you know, spend time chatting, you know, get to know them, understand. I played today, I was just saying how I had a 2-year-old come in with her 4-year-old sister, and they were both fighting to sit on my lap, and you know, and they wouldn't leave. Seriously, mom's like, okay, appointment's done, we're going. No, I want to stay here with my friend, you know. But guess what? That's a patient that I can actually treat well, right? As I get to know them. It's just the way it works. So we have to work within that system and try and make it as effective as possible. So guess what? Do your homework before, okay? Kind of like, I have half an hour to talk to you. I don't know, my time is running up. Anyway, so that's why I have slides, right? I have points. Okay, at least I can do this, or find ways to communicate what's bothering you, okay? At the next visit, don't just go through the regular questions. Each visit, pick up a new topic, okay? You guys need to do that, all right? You need to go, all right, let's talk about the medicine today. Let's talk about the EEG today. Let's talk about other options today. Let's talk about school today. Let's talk about, you know, how much it costs today. All right, and that's how you build that relationship. All right, now, this slide is a bunch of questions that I think have been, you know, floating around. What do doctors think about when patients want second opinions? I think it's brilliant, especially if I really don't like the patient. No, I'm kidding, I'm kidding. You know, I think, you know, I've always worked in a big academic center. And one of the things I really appreciate about that is that I get to discuss anything with my colleagues. I have the best minds working with me, okay? Some of the best minds. I mean, mine is the best mind, but, you know, again, you know, the more information, the more people trying to, you know, understand a problem, the more solutions you're going to get, right? I don't think any reasonable doctor is actually going to be upset that you had a, you know, that you went for a second opinion. You know, of course, we'll be like, I hope they say the same thing, you know, or I hope they think I'm the best and they come back. But, you know, for the most part, for example, every Monday morning, the first thing when our work week starts, we discuss all our patients in my department. I think it's brilliant, you know, things that you don't think about. So yeah, I would say I encourage it. That's not the same as doctor shopping, because then, you know, you don't establish a relationship with anybody and nothing gets done. And you get a little too much information and too many directions and nothing is productive. All right. So does it have to be a level 4 epilepsy center? There are pros and cons, as there are to everything. I think for some complex epilepsies, certainly more pros to a level 4 epilepsy center. You know, the only downside I can imagine to a level 4 epilepsy center or comprehensive epilepsy care might be that, with the number of people coming to a tertiary center, you might feel a little lost, may not have that one-to-one, interaction that you do with your own little doctor and their, little town and whatever. So that's the only downside to it. But obviously, the more minds you have, the more resources you have, the more technology you have, the more OR time you have, nurses, staff, scheduling, and more appointments. That's all good stuff. So yeah, nobody should have to stop you from going to a level 4 epilepsy center. Do you always need it? Maybe, maybe not. But certainly it's worth considering. Okay. Other options, and I mean other options, not just trying other methodologies of treatment. No, I'm actually talking about asking your own doctor about alternative treatments to the medicine that you're taking, or maybe surgical options, maybe dietary options, other things. There is a wide field of research happening, and it's been happening, right? And so you don't ask, you'll never know. Be curious, okay? So, and a really good doctor should be, if they don't know, should be able to find out and let you know, all right? So expect that from your doctors. And what makes a good fit? That's, again, it's really, as I mentioned, we talk about doctor-patient relationship. So that's very personal and it's individual. People need to trust their doctor. That's the only way any treatment is going to work. I am a big believer that if you don't trust me as your doctor, then I can give you the best medicine in the world, it's not really going to work that great. Okay. What kind of doctor-patient relationships are there? Well, there's the active passive one where the doctor just tells you what to do and you go do it, that's really outdated, isn't it? Right? And it's obviously not ideal. There is a guidance cooperation model, which is probably just the same kind of thing, just a little softer on the edges. Mutual participation. And that's what we should really try to achieve. Okay, it's in the best interest of both the doctor and the patient. As I mentioned, the more informed my patient is, the easier it is for me to be able to treat them. Makes sense, right? Now, how do we know that there's a good doctor-patient relationship? Well, we can actually look at some outcomes of that relationship, okay? So over time, we have objective outcomes. So for example, if the seizure frequency is decreased, the quality of life has improved, guess what? Those are all really objective things. You can see the EEG is better, the number of seizures are better, no side effects. Those are objective things. We know for a fact when you started, not so great. Met the doctor, underwent treatment, boom, you're better. That's a successful relationship, right? Behavioral outcomes. Guess what? That's where quality of life comes about, right? Even if their seizures aren't, that well controlled, their coping mechanism, their trust, their overall belief that they will be better, they are okay, that kind of comfort comes from a good doctor-patient relationship, right? You know that, okay, fine, I'm having seizures, but at least I know my doctor will take care of it. Part of it. Subjective outcomes. When you yourself as a patient are much more knowledgeable, you feel like you also are empowered to have control. That's the ideal relationship. That's the outcome that we're looking for. right? I always say, look, me as a scientist, as a neurophysiologist, I'm looking for that perfect EEG, right? So to me, that is success. Well, what did it take to get that perfect EEG? 4 medications, 4 times a day, okay? The kid is a zombie, the mom is even worse. Trying to do that. Have I really succeeded? So I like to think of what I do is try and improve the quality of life, okay? It's not what I think is the improvement in the quality of life. It is what the patient and the parent think that their life is better with. Oh, all right, that's like wasn't important anyway. Basically, what I was saying is, what are the parts of the relationship that matter? Trust. I talked about trust, right? If I, as a doctor, don't trust my patient to give me honest information that they're doing the right thing, what I'm instructing them to do, then guess what? My treatment plan goes out the window, right? If I tell you, here, take this pill twice a day, and I'm thinking, fine, if you take this pill in this dose twice a day, guess what? I'm expecting a perfect looking EEG. Say you don't do it, and you sort of give me some story, you know, then I don't trust you. I don't trust you to show up to appointments. I don't trust you to take the medicine. I don't trust you to get your blood monitored. Guess what? That's not working, right? Same thing. If the patient doesn't trust what I'm saying, how comfortable are they going to be taking that medicine? Not really, are they? So all of those things make such an impact. That's how the relationship makes an impact on epilepsy in general. All right. Now, and then of course we are here in the age of the internet, which, you know, is a relationship breaker, if you ask me, because I don't think we use it appropriately. All right. There is so much information coming from so many different areas, right? And so you have social media, you have Google, you have, you know, so much technology involved, right? Now, Google is great, but it's only as good as the question you ask it, right? So that's where the human doctor comes in, okay? So in my clinic, with my patients, I love when people have gathered information from the internet, you know, things that I might not have known about. I don't have the time to read. What I do not love is when they freak out reading something that is totally not pertinent to them, right? Here's the thing. You know, your kid has a seizure and then, you know, you read somewhere or something and you've decided, oh my God, they've got a brain tumor or whatever, you know, or this is the medicine I should have, right? This person wrote on Facebook that this was a miracle cure. So you come to me, right? I sound like the Godfather. But when you come talk to me, you're already made up your mind, right? Imagine how much tougher my job is, right? So I actually keep in mind that any person coming to me, okay, there is no well visit to a pediatric neurologist, okay? Even if the child is completely fine, parent not so much, but the child is completely fine, I do understand that worry of having to bring your child to a neurologist. So I take that into account. And I think as doctors, we should take that into account. But by the same token, you know, all us moms, there's there's no normal mom. We're just crazy mom. Okay. And we build up, you know, this anxiety and worry and anticipation, and we just go down this rabbit hole, right? So temper your internet search is what I'm saying. You know, use it, allow your doctor to sort of guide you to the right places to look up. All right, it's amazing. We're just talking about how much technology has helped. You know, I know as doctors, we hate the electronic medical record because we have to keep typing, and, you know, I'm sitting here, I don't care what the kid's doing, breaking up my office, but I have to finish my note. You know, that's what, unfortunately, it's like. But guess what? I love the medical record. I'm going to die by documentation, but I do love the electronic medical record because it actually gives me so much information that I would have to dig up. You know, I can look at MRIs from 10 years ago, from other hospitals. That is amazing that we have that technology to be able to do that. Imagine how much more information that is for me to be able to take care of that child, right? Talking about communication, we can do Zoom meetings, we can do telehealth. I think it's brilliant. Telehealth, I love telehealth, especially for established patients. Okay, because come on, you got to look at me first, you know, their first appointment, you really have to make eye-to-eye contact and really get the vibe. But once you know me, right, I like that on telemedicine, the minute 1 to minute whatever, and it's all yours. You're not being, you know, ushered into a room, waiting in a cold gown, you know, none of that nonsense. You're in the comfort of your home. I get to see your home environment, you in a comfortable, you know, environment. I see you in your natural habitat. You know, so, and that's where real life happens. That's where these kids are taking these pills. That's where these moms are running after them. That's where all of this is happening, right? So I like to go to my patients' schools and see where they go, what kind of schools they're in, you know? And that's the part I need for my patient to make this relationship work. All right, okay. I'm sure you guys are tired of hearing my voice. So your turn. Questions? Yes.
That's been you and your knowledge. So when the seizures appear,
yeah.
I'm in the beginning of this.
Your son?
Yeah.
Okay, so you are a crazy mom.
Yes,
okay.
Absolutely. Times 10. So, you know, the next step was boom, start this medicine.
Yeah. So, and you know what? Unfortunately, you know, everyone will tell you. Oh, sure. So the question was, you know, in this lady's case, her son was just recently diagnosed with epilepsy and has tried and failed 2 medications already, and is now on the 3rd. Is this truly the path that they have to go down? You know, one of the things that's really important to understand is, particularly in neurology, in child neurology, okay, every brain, every patient, every seizure is very individual. You know, think about it this way, right? We all have hearts. We were born, you know, minute 0, our heart does whatever it does until the end, right? Our lungs do the same thing, and they do the same thing in everybody, right? Our brains are literally what make us who we are as individuals, different from each other, right? So one of the problems is, again, their epilepsies are also pretty individual, and how they respond and react to medications also ends up being very, very different for each child. Now, you know, sometimes, many times, unfortunately, it is a trial and error type of scenario, you know, especially in epilepsy. You know, sometimes if the medicine works, then it might not be tolerated and we might have to change it. Sometimes you need to add something, you know. Now, it's very, very different, especially in a child, because the brain is still developing, right? And so he's not the, you know, how old is he now? He's 10. Guess what? I always, you know, think of myself as almost like a veterinarian, because I feel I see little babies, I see newborns, I see toddlers, I see school-age children, I see adolescents. Believe me, they're all different species, right? So guess what? Your 10-year-old is going to have a different brain in 4 years, 5 years. When he hits puberty, things change. So his seizures might change, his response to medication might change. And so it's an ongoing process, all right? So don't lose hope, okay? No, those two other ones were just practice. They were practice, okay? But do me a favor, talk to your doctor, okay? Talk to your son's doctor. You know, tell them about your concerns, okay? Look, they may not have the answers, okay? But they can worry there with you, okay? So, yes, and listen, the more you ask, the more you understand, and you will find, especially, you know, you're at the right place, the Epilepsy Foundation. They have tons of people with all sorts of similar scenarios. This is the place to ask, okay? Reach out to people who are in the same kind of scenario. And somebody will be like, oh my God, I had the same problem, you know? And then you might actually come up with the reason why this is happening. All right? You're welcome. Any, yes, Megan.
Some sort of diary,
Sure. Absolutely. So the question is, you know, do you have any resources for the patient to be able to communicate to the doctor all the important information? Yeah. So absolutely. And, you know, certainly the Epilepsy Foundation has, you know, so many seizure logs and, you know, diaries and things like that. And I think it's very important. You know, again, I joke about crazy mom, but I'm certainly one as well. And I can get very anal. And for a lot of us, you know, making note of these things, keeping things organized, understanding, you know, when you have a bit of information, putting it in there. Seizure diaries are very important, you know. As you mentioned, having the pharmacy print out a list of all the medications that they're taking. You know, the veteran moms are carrying, you know, every medication that's been changed and when and how and doses and stuff. Believe me, that makes such a big difference for us, right? And so I think it is important, and that can be, it doesn't have to necessarily be standardized. But this is what I was saying. You know, when you come to an appointment, make it a point every single time. Maybe even if you have only this much time, this time ask this question, next time talk about something else. So, you know, cumulatively, you've managed to get a lot of information on both sides, right? But that's a great, that certainly is very important for both people. And I think, yes, for doctors as well, to write out stuff, write out the instructions. And mention, okay, this is when you're going to take it. These are some of the things that you have to look out for, because we're all trying. And so, but yeah, you hit the nail on the head, communication. Yes.
When parents want to try alternative type of treatments, things maybe that or you
Sure.
don't feel as if it's going to be helpful. How do you manage that? And how do you avoid losing the trust in that participation?
Right. So the question was, when parents want to consider alternative treatments that may not be approved or well-researched, how do I approach that patient, parent, and how do we maintain trust? And that's a very real life question that happens very often, right? And I think it's like everything else that we discuss, okay? So for example, when I am discussing, okay, I'm diagnosing the child with epilepsy in the first place, I will tell you this, most people, when a child has a seizure, don't even know what seizures are, don't know what epilepsy is, and whatever idea they have about epilepsy is kind of misinformed sometimes, right? And so I think the part of it goes along with explaining what you understand about it, and then again, understanding what they think about it, right? Now, when it comes, and that's how over time you do end up building trust and knowing how to communicate and what the other person wants, right? So I think one of the things that actually brings up a good point, what I like to do is once I've established that relationship, very so often, I actually like to make sure that we're both on the same page, as far as our goals, as far as our understanding where we are, what our options are, it's not just about, okay, let me just refill, the medication. For example, and this is something that we talked about at the adult wellness weekend, the goal might be no seizures, okay? But that's maybe the primary goal. People, it's not just black and white, okay? Maybe you want great control of your seizures, but you also want a quality of life, okay? And so maybe you're willing to have 1 or 2 seizures here and there, but you're not on too much medication and you're still able to live a very active life. Maybe that's the balance you need. So these are goals that I think are important to establish ahead of time, right? And then that's where the mutual participation model comes in, okay? So when, an established patient comes up and says, hey, you know what, I'd like to try CBD oil. That comes up a lot, right? And part of it is, it's a great question. You hear about it a lot. And so I explain why I think it may or may not be a good idea for any of the medications, right? And so I think it's important for the doctor to be open, right? There are a lot of medications today, or a lot of treatments or things that we do today that are standard of care that we would have never thought of 50 years ago. So I like to keep my mind open, but at this point, I need to explain everything, why I disagree with that, if I do, right? And then offer alternatives. So it's like any relationship, to be honest, right? Which is why I don't like when you start out the whole appointment with, here, this is what I'm here for. Okay, well, then why are you here? Am I a vending machine then? You know, just because I have a license, I can write it out for you? That's not how it works. So I think that trust ends up being built on both sides. Okay, imagine I have a tough job of trying to convince parents to have their kids have epilepsy surgery, right? And so, yeah, mom here is like, what? But the thing is, I need to convince you that that is the right course. And that's not just for surgery. I think it's important for anything that I prescribe, anything that I say, I need to explain why I'm doing it, how I think it's going to help. That builds trust. So I expect the same of my patients towards me as well. I hope that answered your question. Yes, Rainer. Mm-hmm.
Do you ever hear of students a seizure to get out of school?
Great question. Yes. So the question was, do you ever come across students who misrepresent a seizure to get out of school or homework or, you know, responsibilities? Interesting. Well, here's the thing, right? I think there's always a risk of that happening, right? What is the ulterior motive, right? But here's the thing. What can I do if I always tell patients who I might worry might be faking a seizure or whatever, guess what? My response to that is to give you Diastat. So if you're okay with that, which is rectal diazepam, which is a treatment for the seizure. So if you're okay to have a seizure in school and get Diastat, well then, you know, so be it. I'm sorry. You know, it's part and parcel of what we see. And it's important to understand exactly, right? Because there are epileptic seizures, there are non-epileptic seizures, you know, and so all of this comes within diagnosis and treatment and management. So, yeah, but I guess that answered the question. Yes. Mm-hmm. Okay. So, you know, so the question was, there's another child who was diagnosed with epilepsy at 8, is now 10, has been through multiple medications and still continues to have at least a seizure a week, particularly in school. Yeah, at least 3 times. Yeah. Oh, wow. 3 times a week. And so, yeah, these are very complex situations. And this is why and when we need the best minds to think and figure out what might be the best option. You know, in pediatric epilepsy, even the thought, when epilepsy surgery became a thing, obviously pediatrics, we were like, oh, well, yeah, you're not touching my baby's brain, you know? So you're a lot more reluctant to undergo surgery, right? Not only that, in pediatrics, we have a lot of epilepsy syndromes that kids outgrow. So we worry that if it's something that they might outgrow, then why are we taking more drastic steps? However, now, as my colleague Sarah will be talking about, we have so much more information about such complex epilepsies. we can figure out maybe there is some sort of mutation, genetically speaking, and that brain is predisposed to having, you know, uncontrolled seizures, in which case maybe medicine is not the answer, right? And maybe surgery would make for, and there are so many different levels and varieties of surgery available today. So, you know, this is certainly, if you're thinking about it, ask your doctor. Believe me, your doctor will be more than happy to discuss the next step and other options. All right. But again, just like the doctor needs to be open to what the parents are saying, parents also need to be open to the ideas that alternative therapies other than just medication might work. Does that answer your question? All righty. And that's a wrap. Thank you, everybody. What's her name?
Thank you, Dr. V. Someone had to leave that was here with his daughter, and he wanted you to know how much he appreciated your talk and your honesty. So
Actually, and if, you know, just let them know that I should be available. You can ask me questions.
absolutely.
Through the app, then I'll be happy to answer.
Yeah, I appreciate it. Thank you so much. I think we're going to go right into our next speaker because we started a little bit late, if that's okay with everybody. So our next speaker is Sarah McKeown Ruggiero. Did I say that? I'm really bad. No, and you know what I do for names? I go on YouTube and I say pronounce the name, and I did that for yours. And I immediately forgot. So, so sorry for butchering. I do deserve an A for effort, though. So Sarah is a genetic counselor who specializes in the genetics of epilepsy and related neurodevelopmental disorders. She has a long-standing interest in neurodevelopmental disorders and worked as a research scientist within multiple laboratories, exploring the pathobiology of neurodevelopmental disorders before becoming a genetic counselor. Within the Helbig laboratory, she serves as a link between the clinical and research efforts of the Epilepsy Genetics Research Project. One particular area of focus is her work on the gene STXBP1, specifically better methods to categorize STXB1 related disorders. She has an MS in genetic counseling from Acadia University, as well as a BS in neuroscience and a BA in English from the University of Delaware. Please welcome Sarah.
Thank you.
And this is to advance the slide.
Okay, excellent. I click the button. Yeah, okay. Wait, it went too far, maybe? That's okay. First couple of slides weren't important anyway. So, hi everyone. I'm Sarah McKeown Ruggiero. Like Ellen, say it again. Click 2 times. No, that's okay. Okay, we'll start here. So, like Ellen kindly introduced, I'm a genetic counselor. I work at the Children's Hospital of Philadelphia, and within a clinic that's called the Epilepsy Neurogenetics Initiative, or the ENGINE Clinic. And the whole point of our clinic really is to find genetic diagnoses or genetic reasons why children and some young adults have epilepsy and related neurodevelopmental disorders. What related neurodevelopmental disorders means? Things like autism, developmental differences, things like that, things that we know happen a lot in people who have epilepsy, or happen more often, right? And so the whole point of our clinic is to find genetic answers for kids with epilepsy, and then to use those genetic answers to give better treatment for kids that have genetic epilepsies, right? And to help people understand in many ways why their child's brain works differently. What exactly is different about your child's brain, or your brain, if we're talking to older children, right? That makes you have seizures, makes you have epilepsy, right? And so in my talk today, I first want to talk about what is a genetic counselor. So a lot of people don't know what that job is. And so I think it's a good place to start to introduce it, right? I want to talk through how can genetic differences or genetic variation cause epilepsy in people. We're going to talk about why it's important, or why it can be important to know about genetic differences, and how it can affect how we take care of people, or how it can change people's lives in other ways, right? I'm going to talk about how, just logistically, we find these genetic differences. So how do we do genetic testing? And then I'll have time for questions at the end, okay? So to start off with, what is a genetic counselor? So a genetic counselor is an advanced practice provider. So think something like a nurse practitioner, not a doctor, but a person who has specialized training in a subject, right? And we are trained in genetics and counseling, right? Genetic counselor, it all ties together. But what that means and what we do every day, we are a profession that's growing. We're a profession that's growing, and we have knowledge of genetics, genetic testing. We're trained in scientific teaching and communication and psychosocial counseling, because when you give something as critical or as sometimes life-changing as a genetic diagnosis to a person, that is going to have an effect on a family, right? That's going to have an effect on a person. And so a genetic counselor has the science training to help teach what it means to have a genetic diagnosis, but then we help deal with the impact of that on the psychological level, right? Because we're not just talking science here. This can't just exist in a vacuum. We have to take care of a whole person. So genetic counseling, there are genetic counselors for most things you can think of now. There are genetic counselors for cancer, for cardiac problems, for most people see genetic counselors if they've ever seen one. Most of the time, they see one when they're pregnant. But now there are increasingly genetic counselors that specialize in neurology, like me, and that specialize in taking care of kids who have epilepsy and neurodevelopmental disorders. Okay, and so now that we all know what a genetic counselor is, let's move to how genetic differences can cause epilepsy, right? But before we talk about how genetic differences can cause epilepsy, I want to talk about the things that can cause epilepsy in general, right? So we're going to focus on the genetic reasons. So genetic epilepsy can be caused by differences in a person's chromosomes or packages of genetic information. We're going to get further into this. So okay, if you don't know these words, it can be caused by differences in single genes. We'll talk about what that difference is. Epilepsy can be caused by structural differences in the way the brain works or the way the brain functions. So that can be a difference of the brain that a person's born with. It can be a birth injury, or it could be an injury that a person gets later in life that causes their seizures, right? Some brain differences that people are born with can be genetic too. So it's not an exclusion, right? Some people have epilepsy because of infectious reasons. So they can have a virus that infects the brain that then causes seizures. Can have a metabolic disorder that causes seizures. An immune or a autoimmune type of epilepsy problem. And then there are many epilepsies where we don't know the reason why people have epilepsy. And so there are all of these different reasons. Some that are not even in the genetic category are also genetic, but we're going to focus on the genetic portion of things today, okay? And it's a bit of a complicated graph, but I'll break it down for everyone. We know that most epilepsies that affect children are genetic. Most of the time, it comes down to genetic differences in a person that lead to their epilepsy. Problem is, even though we know most epilepsies are genetic, we can't find that answer every time for a person. We can find it a good amount of the time, and I'm going to explain later on why we think we should do testing for every person who has an unexplained epilepsy. But so we can't find that difference every time, but most of the time we know it's genetic. And it's something, even if my patients didn't know this, like, you know, didn't learn about it in biology or when they took their genetics course or something, a lot of people know it kind of intuitively. For example, I'll have a mom come to me in clinic and say something like, yeah, I always knew that I would probably have a child with epilepsy because my grandma and my aunt have epilepsy too. And so I always just kind of knew it was a possibility for me or something. So it's something we know intuitively. It's something people have thought to be true since the age of Hippocrates. Hippocrates has a quote where he talks about how genetics, or where the source of epilepsy probably lies in heredity, or the traits we share with one another, right? So most epilepsies are genetic. We just can't find that answer for everyone, but I'll talk about how often we can. Okay, but before we dig further into this, I want to refresh on some vocabulary, right? Because a lot of people don't think about genetics and genetics of epilepsy like ever, or maybe you haven't learned about genetics since high school or something like that, right? And so I want to start off really basically with just, what is a gene? What does that mean, right? So genes, most basically, they provide the instructions that make our bodies function. So our genes, you can think of our genes as like an instruction manual on how to make every part of our body. That can be our skin, our hair, our eyes, and of course our brain, right? And so this is just a breakdown of what is a cell, what's a chromosome, what's DNA, right? Our cells are the building blocks of our bodies. Within our cells are our chromosomes, which are the packages of our genetic information, right? And contained within those chromosomes are our DNA, which contain our genes, and the genes are the instructions that make us who we are, right? So that's kind of the pattern. The most important thing to remember from this, though, is a gene. Gene is just an instruction that makes us who we are. And so our genes, like I said before, provide instructions for every part of us. So we have many genes in us that tell our eyes what color they should be and how our eyes work, right? We have genes that make my hair blonde or red or whatever it is, and make other people's hair brown or black, right? We have genes for every single thing. And because we have genes for how our hair looks, how our skin looks, how our eyes look, we have genes that tell our brain how to function, that make our brain and then tell our brain how to function. So our brain needs instructions for how the brain cells get made initially. It needs instructions for how our brain conducts electricity, right? So if epilepsy is like chaotic electrical activity, we can have differences in the way that our brain makes electricity or conducts electricity, and that can lead to epilepsy, right? We can have differences in the way that our brain cells talk to one another. Our brain cells need to communicate back and forth. And if we have differences in how our brain cells talk to one another, that could lead to seizures. So if there are variants that occur in these brain genes, and variance just means everyone has differences in our genes that make us different from one another, right? That's why I use the word variant. I try not to say mutation as much, because people with genetic disorders, they're like, I don't have a mutation. I'm not a mutant. I have a variant. I'm a variant, right? And so we try to use the language variant because, and so we have these variants that are in brain genes and make them not work typically. And they can result in things like epilepsy, developmental differences, things like autism, which all overlap with one another. I'm gonna skip this slide. So now that we've talked through how genetic differences can cause epilepsy, how does a change that's buried in a little gene cause an effect in my brain, right? I want to talk about why it can be important to know about these genetic differences. So the first and perhaps the most important thing is just a need for an answer in many ways, a need for an answer. So when we give a parent a new diagnosis of epilepsy for their child, the first thing that we often hear from them is, why did this happen? Where did it come from? I don't understand, right? And that's kind of the core of what we do within the Epilepsy Neurogenetics Initiative within my job. That's what I do as a genetic counselor. I'm trying to help us find out why this happened, where it came from, and sometimes that answer is genetics. And so some of the most powerful work that I can do is sitting down with a parent once we know the genetic difference in their child and explaining why exactly their child's brain works differently, how exactly the brain cells conduct electricity differently, how the brain cells talk to one another differently. Dr. V said before, knowledge is power, right? And I really believe that knowing how those differences work and manifest make a difference in how people see epilepsy, see this disease that they're treating in their child, right? So I'm gonna take a sip of water really quickly. I'm talking quite a lot, aren't I? Okay, so next thing is prognosis. Prognosis, meaning what might happen in the future for my child, right? So is there anything besides epilepsy that I need to worry about? Like, do we need to see any other specialists to help take better care of them? Are the seizures gonna go away in the future? So sometimes we can find a genetic diagnosis that tells us the seizures are likely to go away by the time your child is 2 or by the time your child is 5 in some cases. So sometimes we can find a gene that tells us that ahead of time, right? We can get treatment guidance sometimes from knowing the genetic difference causing an epilepsy. So for some genetic diagnoses, we would make recommendations not to use certain medications because it could be dangerous. And sometimes we can make recommendations for medications we know work better, right? And so treatment guidance is a big reason. And then we can talk about, especially for very, very young babies that I take care of, and that's kind of my specialty, is the 1-year-olds and less. When we see a young baby presenting with epilepsy, we can talk to parents about, is there going to be an effect on their development in the future? There are some genes that we know of where we can say, unequivocally, your child is unlikely to have any problems with their development, any differences in development because of this gene. There are other genes where we have that conversation very early on that there likely will be differences with development that happen in your child's lifetime. But what's the advantage, in our opinion, of knowing that ahead of time is preparation and therapies from the very beginning and getting people access to everything they need right from the very beginning, right? Okay, so prognosis. Then there's chance of recurrence. And that's a fancy way of saying will this happen again? Or could this happen in another member of my family or something like that? So if we know a genetic diagnosis, we can give very kind of concrete chances of having another child with epilepsy. And they can range quite a bit, and it really depends on the gene. So we can learn a lot from that. Social support is a huge, huge, huge one. So just like the Epilepsy Foundation exists, there exists foundations for specific genetic epilepsies where people can get support from one another, can band together to fund research, I don't need to talk at an Epilepsy Foundation event about all of the reasons that connecting in that way is important, right? But these exist for genetic epilepsies too, and people can really get a lot out of this type of social support. And increasingly, there are now genes where we know there are going to be opportunities for access for clinical trials in the future and access to different research opportunities. And so but the way into that is a genetic diagnosis for a lot of children. So, okay, and then, so the big question. So how often can we find an answer for a person with an unexplained epilepsy that we think is probably genetic, meaning we don't see anything on the MRI that makes us there wasn't an injury that caused the epilepsy. There's no like lesion on an MRI that we think is causing an epilepsy, right? Where we think it's probably a genetic cause. So a person who has epilepsy only and no differences with learning or developmental differences, we can get a genetic diagnosis about 10 to 15% of the time. And to some people, I give that number to like every patient who's in this situation who I counsel, right? And some people will be like, well, that's really low. Why are we doing this? Some people will be like, that's a lot higher than I thought. And there's no in between, right? So we think that 10 to 15% chance, we think it's high enough to warrant doing genetic testing for every person who wants it, right? And trying to find that answer, because to us, 10 to 15% chance is a pretty high chance of finding an answer, especially when the consequences, or not the consequences, but the advantages of what can come with that are so great, right? Epilepsy, in a person with epilepsy who has mild learning differences, that chance goes up. That's just because we have had a longer time to understand the genetics of why people learn differently from one another. And so we've just made more progress, but we're making more progress in the epilepsies, and that gap might change. People who have developmental and epileptic encephalopathies, it's a very complicated word, but it means people who have very severe epilepsies that start early in life and come with big consequences to development too, or seizures are so intense that they interfere with a person's development, our chance is much higher at finding an answer. It's around 30 to 50%, depending on a person's specific seizure type and diagnosis, right? And then if a person has epilepsy, so a difference with their brain, but then a difference not affecting the brain. So a difference with their brain plus a difference that affects maybe their heart, their musculoskeletal system. So so they might have hypotonia and epilepsy, for example. That chance goes up a little higher too, because it's more likely, because genetic differences often affect more than just one system, more than just the brain. It can affect other things too. And so if we have multiple systems in a body affected by something, we have a higher chance of finding that answer, right? Okay, quick word on chance of recurrence, because this is often the first question that people will ask me at the end. So a question I get every day really is, if you have one child with epilepsy, what are the chances of having another child with epilepsy? Does anyone who doesn't know the answer want to take a guess? Maybe shout it out. 50-50, you said? Less? Much less? Like how much? 10% it. So if we don't know, if we don't know a specific genetic diagnosis for a person, the answer to this question of what are the chances of having another child, I have one child with epilepsy. What are the chances I'm going to have another child with epilepsy? It's around 10%, right? But if the chances are a little greater, if a person has if you have a very strong family history. So I meet a lot of families in clinic where it's like, my grandpa had epilepsy and my dad had epilepsy and now I have epilepsy and now my child has epilepsy, right? So the chances for that family are going to be a lot higher. And it very much varies it varies greatly from family to family, but in general, the number we give is about 10% without any other information, right? And no one should know what these are, so no worries there. But what if we know a genetic diagnosis? Because if we have a genetic diagnosis, then we can give a lot more specific information. So, and what these are just, these are called pedigrees or tree maps of a family. And so a person is shaded in if they have a condition, they're unshaded if they're not. And so if you see a genetic counselor, you might see them draw something like this for your family to try to narrow down what's the gene that this could be based on the pattern I see in the family, right? So it's a way of seeing patterns. So if we know a genetic diagnosis, I do a test on a person with epilepsy. I say, you have epilepsy because of a genetic difference in a gene that's called NPRL3, for example. I would have to say, if you have a child in the future, that child has a 50% chance of getting this gene and having epilepsy, right? But conversely, so sometimes genetic differences can happen brand new in a person and not run through a family at all. So what's very, very common is that I have two parents that don't have epilepsy. They have a child that does have epilepsy, and there's no family history whatsoever. So you don't need to have a family history to have a genetic epilepsy. That's a really important lesson to get out there. If there's so that child can have a difference that is new in them, a genetic difference that's new in them, not present in either parent, right? And the chances of those parents having another child with epilepsy would be 0, right? Because it happened brand new or essentially almost 0. Because the chances, because happened new in that person and it's not carried by either parent. So the chances of it happening for another child are very low, right? So it really can range quite a lot depending on the gene, depending on the situation, but we can give that very concrete information if we know what the answer is, which is what's really helpful for people. Also, so some family members that are unaffected, but who might want to know, could I have a child that has the same thing as my cousin or something? They could be tested for those genetic differences too, to find out that information, right? All right, and just some thoughts about genetics and how it can what it can tell us about prognosis and things like that. So sometimes not always, but sometimes we can find genetic diagnoses that tell us if seizures are likely to continue in the future, if seizures are likely to get worse in the future, get better in the future. It very much depends on the gene, but we can get that type of information, which can be very, very helpful for families, right? I've already talked about this, but we can sometimes find out what medications might be most helpful, learning and developmental outcomes, things like this. But one thing I really want to say is that genetics is not a crystal ball, right? So we don't have that yet. We don't have that yet. No one's invented it. And we can't really, so sometimes so while genetics can give us guidance about what might happen in the future, it can't tell us exactly what's going to happen in the future. And when I'm giving a new diagnosis to a 1-year-old, something a doctor I work closely with and I kind of like to tell parents is, let's really just work through till your child's 5 or something. Let's think that far ahead, because because sometimes we'll give a new diagnosis to a 1-year-old and parents will ask us back, like, well, will he be able to go to college? Will he be able to drive? Will he be able to, right? And for that type, for a 1-year-old, right, we wouldn't be able to answer that for any 1-year-old that came into our office, if they had epilepsy or not. We wouldn't be able to answer that question. And so genetics doesn't suddenly give us that ability, right? Which is really important to understand. So genetics can give us some really good medical information, but it can't tell us absolutely everything about a person. And that's just an important expectation that important expectation to have going into any genetic session or anything. All right. Okay. So what this slide is, I mentioned this earlier, but there are many, many gene-specific family foundations, disease foundations that exist for genetic epilepsies that drive research forward for these conditions and also offer a home for people who are dealing with epilepsies that are very, very similar to one another. Because you can imagine each and every one of these genetic epilepsies fall into a similar pattern, and kids tend to have epilepsies that look very similar to one another if they have these genetic differences. And so sometimes people can really feel quite at home in these gene-specific organizations because they have people that know their experience and are dealing with things that are very similar to what they're dealing with, right? So I work very closely with the one in the top right corner, so STXBP1 related disorders. I work very closely with that foundation, but every genetic counselor that's part of my team has a different partnership with each one of these, right? And connection with family foundations is how we do our best work. So I would be remiss if I did not talk through them. All right, this got a slightly off kilter here, and this is a little bit of a complicated slide, but I just want basically the whole only point of this is a really big research study that was done where over 10,000 people with epilepsy were tested to see what are the genes that came up most frequently. And the top one, so 25% of the time, comes down to a gene that's called SCN1A. And people might know that as the gene that causes Dravet syndrome, which is a common epilepsy condition. So there are about 13 genes that are listed there where we see kids who have those genes all the time. Every single day we have a clinic, we have a kid who has one of these diagnoses, right? But then going down the screen, you can see a long, long tail. So there are over 1,000 genes that have been identified that have been found to be related to epilepsy in some way. So I am never going to know every epilepsy gene of what comes into our clinic, right? Because I'm always going to need to learn about a new diagnosis. That doesn't mean that we can't give really good information from it. It just means that I have a lot of reading to do before that person comes in, right? So this is just what the genetics of epilepsy looks like. The top 13 genes see all the time, but this tail is long, 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 and it'll probably keep getting longer as we find out more things, right? Okay, and then finally, how do we find these genetic differences, right? So the test we choose is going to depend on the epilepsy presentation of a person. So what type of epilepsy do you have? What seizures do you have? Does it come with any other symptoms? all of that, right? So every person, every clinic has a different pattern of how they'll choose a test. And it really just depends on what kind of epilepsy do you have, right? Genetic testing can be done on blood samples, but also saliva samples. And saliva samples are what we use most often, because if we can protect our kids from like one stick, let's at least put that good in the world, right? And saliva samples, a lot of people will joke when they come in to see me. They're like, this looks exactly like what I did for 23andMe. And it is, it's the same exact kit. We just send it to a different place, right? So if you've ever done 23andMe or Ancestry or something, same exact kit, we just send it to a clinical testing lab instead of, one of these companies, right? I get a lot of questions isn't genetic testing expensive? What are the chances my insurance will cover it? Things like that. Insurance companies are really increasingly willing to cover genetic testing. I can't say they always will. I will say that in pediatrics anyway, in the kids that I take care of, I rarely run into a situation anymore where I can't get affordable testing done for my patient, for a family who wants it, right? And that's true. So people who have Medicaid, we can send a test. Medicaid's the easiest insurance for me to work with. I can send a test immediately to a lab. I don't worry about authorization. I know my family won't get billed. Who knows what happens on the other end? I don't care. I just want testing for my patient, right? Any person, really, I've taken care of over 1,000 kids who have epilepsy in these past 3 years. Rarely do I run into a situation where we can't find an affordable way to get I okay? Now that I put that out there, I'm going to get angry emails next week saying, there are exceptions, but really, we have good luck. Genetic testing is increasingly thought of as standard of care for people with neurodevelopmental disorders. So there have been recent guidelines put out there by guiding organizations that say that people who have things like intellectual disability and epilepsy should be eligible for genetic testing, right? If appropriate, if we think they could have a genetic epilepsy, it's recommended that people get genetic testing to help understand. And one other thing to mention, so insurance companies, yes, increasingly willing to cover genetic testing, but there are many, many sponsored testing programs, meaning completely free testing programs for people with epilepsy, especially for children under 8 years old. So there are a lot of creative things that we can do to get testing done affordably. How am I doing on time? Am I going a little long? We're okay. Okay. So how can we find that should say epilepsy and not autism, apologies, but how can we find genetic causes for epilepsy? So we can do a bunch of different types of tests. We can test single genes, but we don't really do that anymore. It's a little, it's kind of how things used to be done, but we don't do it so much anymore. We can do a chromosomal microarray. What a chromosomal microarray is, it's a test that looks at our chromosomes, the packages of our DNA, of our genetic information, right? And it looks for missing or extra pieces of those chromosomes that could be causing the symptoms we see in a person. So it's like a picture of our chromosomes looking for missing or extra pieces. Sometimes those are reasons why people have epilepsy, right? Can look for a gene, or we could use technology that's, rather than looking for missing or extra pieces of DNA, it's like a DNA spell checker almost, right? It's like the spell checker you'd use in a Word document. It's looking for spelling differences in a person's DNA that could explain why they have the seizures that they do. So we look at we're basically spell checking genes that are responsible for how the brain is made, how brain cells talk to one another, and trying to find those differences that in the genes that make those things that could have caused the brain to work differently, right? So if you're trying to see why something works differently, we go back to the instructions. And we're basically spell checking instructions with gene panels, which are more targeted. They're looking for about anywhere from 10 to 100 to 1,000 genes, or exome sequencing, which is a test that we do where we test all of the genes we can simultaneously. This is a complicated test, an expensive test, and it takes 3 months to do because it's so complicated. But increasingly, we do this more and more often to find out why children have seizures. So if a person has epilepsy and learning differences or intellectual disability, they are eligible for exome sequencing, and we do it for every child. All right, and then once we do the testing, what does the result look like? So just like any other medical test, really, the type of results that can come back are, it can come back positive or negative. Positive means we find something, negative means we didn't find something. But what's important about a negative genetic test is negative doesn't mean not genetic, right? Just means it's not genetic due to genes that we can look for right now. Because even kids who have severe epilepsies that we know are genetic, we can only find that answer about 50% of the time at best. So that means the other 50% of the time, we just don't know their gene yet. We're trying to change that. We're doing a lot of research to make that different, but we can't find that answer for everyone. So we can say negative for the genes that we know about, but we cannot say right now, you don't have a genetic epilepsy, right? So positive, negative, and then there's a dreaded type of result we can get with genetic testing. It's called a variant of uncertain significance. So it's not quite a positive, it's not quite a negative, somewhere in between, right? And this is a variant of uncertain significance, means it might be it might not be. We can't really say until we have more information, right? That's as specific as I can be right now, just because variants of uncertain significance, that could be like a 40-minute presentation in and of itself. So another way that people describe genetic changes are along this spectrum that are at the bottom of the slide, right? So anywhere from a genetic difference or genetic variant can be benign, meaning it's just a random variant running through a family, not doing anything at all, right? Or all the way up to pathogenic, meaning it is disease causing every time. If you have that genetic difference, you have that disease, right? In the right context. So, and this is just a sample genetic report. This is just a, sample report from a lab, doesn't belong to any person. And this is what genetic testing will look like though. So you see at the top, it says it's an epilepsy next panel. We tested for 124 genes that are associated with epilepsy. And what comes back is a difference in this gene, SCN1A. It says there's a pathogenic mutation in this gene, meaning a disease causing variant that causes this person to have SCN1A related epilepsy. And then on the bottom, there's just more complicated information about why it causes disease and everything. But that's really it. That's kind of what a genetic report looks like. And you can see that if you're not used to reading these all day, every day, like I am, they don't make a lot of sense, right? And that's why genetic counseling is just as important as the genetic testing in and of itself. You need someone to be able to explain to you what this means, right? And so that's why our clinic exists, to kind of guide people through this process and explain what this means at the end. All right, and then just an example of the type of information that we can find out. So say I have a young baby, maybe a 3-month-old that just started having seizures, right? And it just started having seizures, and they're pretty well controlled right now, but we go through genetic testing to try to find out what might happen in the future, right? And so for that 3-month-old baby, we can find many different genetic possibilities. So one genetic possibility we could find is a gene I've talked about a lot today because it's the most common one. It's Dravet syndrome or SCN1A related seizures. And if we find out that that's the baby's diagnosis, then we do have a big conversation ahead of us, because what we find in that situation is that we expect that the child will probably have more seizures in the future. We know that there's certain medications they should avoid. We know that there are certain triggers for seizure that we would really want this child to be careful about. But now we know this information, and we can use that information to take the best care of this family, right? And on the other side, PRRT2 related disorder is another gene that we could find. This gene is just the opposite, really. So when we find out that a child has PRRT2 related disorder, we can have the conversation, your child's seizures are likely going to go away by the time they're 2 years old. They do in 95% of people. We don't expect there to be problems or differences with their development. And we have a medication that we can recommend right away that we think is going to be the best one to control your baby's seizures, right? These two syndromes are as common as one another. They're just as common as one another. There are certain things about, I kind of simplified the situation a little bit. There are certain things that would make us lean one way or another way, but you can see that genetic information in this example would make all the difference for what we would expect in the future, right? And so this is why we think it's so important. Okay, and so who should get a genetic evaluation? Who is this important for? So we think that any person that has an unexplained epilepsy, if they want to get genetic testing, they should be able to get genetic testing. So if you have an epilepsy that's not related to a known traumatic brain injury, a tumor or a cancer past or present, in an injury caused by an infection or an infectious cause or an autoimmune cause, anyone that doesn't really fall into that bucket, we would say has an epilepsy that's not fully explained, we could go forward with genetic testing. Neonates through adults can benefit, and these services exist. So they don't just exist at CHOP, they exist at Geisinger. So they exist at Geisinger, which might be a little closer for some people. Geneticists are everywhere, but a lot of people don't know these services are out there. And for adults, there are adult epilepsy genetics clinics that exist. So there's one at Penn. We see young adults at CHOP, young adults like through about age 30 or something or so. And we especially recommend a genetic evaluation for people who have a family history of epilepsy, people who have developmental differences with their epilepsy, and people who have really difficult to control or intractable, the medical term, for their epilepsy, because sometimes a genetic diagnosis can give us some insight into next steps and things like that, right? Okay, and so this is my last slide. So what are the new challenges that we're dealing with when we think about genetic epilepsy? So sometimes we find a gene that's an answer for a child, but it's so rare that parents will say like, okay, we found the gene. It doesn't really, there's maybe 15 other people we know about this and that have ever been reported with this gene. What does this really tell us, right? Sometimes, so we don't run into that too often, because that genetic information still gives us a lot of other stuff to work with, right? But sometimes we have a diagnosis, but it's like, what do we do now, right? what do we do now, or how can we move forward when we don't know a ton about this gene? There are other genes where we really do know quite a lot, and we can give really good information, right? How do we best describe diagnoses in research, and how do we describe these diagnoses best to families? So this is, I take care of families half my time. Half my time is spent being a researcher, trying to find new genes that cause epilepsy and trying to better describe genetic diagnoses that we already know about. And one study that I'm doing or I'm working on is asking parents directly of kids who have a genetic epilepsy, what is your experience taking care of your child, right? And we're using that research to directly inform like definition of this disease. That's what we're trying to do. So that when I get a new family in clinic with a new baby who has this diagnosis, I can give them the best information I possibly can, right? So that these are challenges that we're working with and trying to figure out as a group. Variants of uncertain significance are always a thing. Like I said, that's a discussion for another day. But sometimes we get these variants where we don't know if they're answers or not, and that can be really frustrating. It's hard to know how to deal with them sometimes. And one thing that we are seeing as we're doing more genetic testing is that genetic differences that we thought could only cause conditions that were really severe before, we're finding them in kids who have very, very mild presentations of the disorder. And so sometimes we get a diagnosis of a gene that if you read a paper about it, seems really scary, but then you look at the kid in front of you, they're doing wonderfully, right? And so sometimes a phrase we use constantly in our clinic is like, your child teaches me much more about this gene than this gene teaches me about your child, right? So we're constantly learning from our patients, and we're constantly learning how big that spectrum can be of how kids can be affected by genetic epilepsies. So if you're interested in seeing a genetics team or having your child evaluated, having yourself evaluated, we do have services available at Children's Hospital of Philadelphia, the Epilepsy Neurogenetics Initiative. So our contact information is engine@chop.edu, engine without the E. You can also Google us and contact us through the CHOP website, but it doesn't need to be at CHOP. You can ask your doctor for a referral for genetic testing that might be closer to you. And often genetics visits are mostly talking. They're not a lot of evaluating, and often we can ship saliva collection kits directly to a person's home, right? So you don't even need to come in for a sample. So often video visits are a really great option for genetics consults, but it really varies state by state. So regulations vary state by state of what kind of if you can see someone in Maryland or Virginia or name a place, right? So I would say that these services are available, and Google around or ask your doctor, and they are out there. So and just questions if people have them, and I'll leave it on this slide of this whole team of wonderful people I work with. So yeah.
Is there like a possibility you might not even be able, like someone has epilepsy, but then they don't carry the gene that would give someone else epilepsy? Is that even a possibility?
Yeah, so the question was, is it possible to have epilepsy but not carry a gene that would cause someone else to have epilepsy? Did I get that right? Oh, okay. So like, could a pregnant woman give her child epilepsy or something like that? That's a really great question, and one we get a lot. So, it's the worst answer in medicine and genetics. It depends. No one likes that answer, but it is true. So sometimes epilepsy can run through a family, but not every person who has that gene causing epilepsy in the family, not every person who has that gene has epilepsy. And so sometimes a person like a woman who has a child doesn't find out that she carries a gene until her child is born, has epilepsy. We test her, find out she has the gene too, right? And so I wish I could be more specific than that, but yeah, so it is a possibility for it to for genes to not have an effect in every generation, or for people to be, or your gender can matter sometimes, or your sex can matter. So like females can be carriers of genes that only males are affected with, for example. So it really, really depends on the genetic difference. But yes, genes can skip generations and things like that. But one other thing I hear in that question that I want to make sure I talk about is like the idea of giving a child or giving another family member epilepsy. So this is, I think, some of the most, I can talk about genetics all day long, but one of the most important things that I do when I talk to my patients is tell them, you did not make this happen for your child, right? You did not, even if you carry a gene, even if a gene's running in your family, you didn't make this happen for your child. We all have genetic differences that make us different from one another, that make us look different from one another, act different from one another. Having genetic differences is just being human, and having these things run through your family is just, it is the most human thing, right? So even if we find out there's a genetic difference leading to seizures, you didn't do that. You didn't make it happen, right? And there's nothing that women can really do in pregnancy that can make that chance happen for people, barring rare things, right? Barring rare things. So anyone who knows me knows I can never give a short answer to a question, and that applies here too. So I'm sorry, but did I get at it okay? Okay, thank you. Hi, yes. Yeah.
My daughter is a patient at CHOP.
Uh-huh.
Had genetic testing first arrived maybe 8 months ago, but it was inconclusive.
Oh.
Does that mean you will and when you do find a gene impact, will you get a call, or should we retest every year?
I am so thankful for this question. This is lovely. Okay, so I'm going to try to paraphrase. So this question is from a mother who has a child taken care of at CHOP who had genetic testing that was done 8 or 9 years ago. And she's asking, like, am I done? Should we do more? Is she in the system? And will we hear if a new gene is discovered or something? It's a great, great, great question. And I wish I put it in my initial presentation. So thank you, anonymous lady. So we do recommend for children who have a likely genetic epilepsy that don't have an answer, we recommend retesting or at least looking at the genetic workup again every 1 to 2 years, because we constantly learn new genes that can cause epilepsy. 9 years ago, we didn't have, so exome sequencing, a test we use all the time now, we rarely used it 8 or 9 years ago. And now we use it all the time. And that gives us about, probably in 2009 testing would have been maybe 10 genes maximum. Now we have 1,000 genes we know about that can cause epilepsy, right? So if you, it's important to take another look. If it's been a long time since you've had a genetic workup, we recommend taking another look every 1 to 2 years for a child who's undiagnosed. So thank you for that question. That's a very important point. Yes, hi.
How about whole genome? When do you recommend it?
Yeah.
Is that possible? Like, is that the next step?
Great question. So someone here asked, what about whole genome? Is whole genome ever an option? And that's a little bit, that's a bit more of a complicated question. So I'm gonna back up and explain what whole genome is. So mention whole exome. Whole exome sequencing is already a very comprehensive test, but it is looking at 2% of our genes. So it's looking at the most important parts of our genes, but that's only 2% of our genes, right? And sometimes that doesn't find an answer for a person, even who has a clearly genetic epilepsy. So what if we looked at the other 98% of our genes through whole genome? We tried to find differences there. So that gives us a little bit better of a chance of finding an answer if exome's negative, about a 5 to 10% chance above exome sequencing. So in kids who are, so number one, there is only one insurer in the US that covers whole genome sequencing. So it's not a test that's available, that is accessible to most people because it's very expensive and because it's not covered by insurers, right? But sometimes they're available on a research basis. So people will run research studies where we try to find more genes that can cause epilepsy. You can get them done that way. And sometimes they can, sometimes people are willing to pay out of pocket for that additional chance of finding an answer. So right now, whole genome isn't really a test we use routinely. It's not something we do all the time, but like our clinic, I can say, is involved in some research studies where we do send this out for our most complex cases and where we try to find diagnoses. So in the future, that's probably going to change. I can't say how soon, maybe 1 to 2 years or so. We might do genome more often, but right now it's only something we can do in like very, very rare cases. And exome is our best chance at finding an answer still, even above genome sometimes. Yes.
Our doctor had said, you know, you're going to get more questions than answers.
Yeah.
From it. So be aware of that.
Yeah.
We registered as part of the Rare Genome Project.
Oh,
so
excellent.
Paying for it, but it's part of the research.
Yeah. Okay. Yeah, that's great. That's great. If you can find those research studies to get it done, that's perfect. And it also helps give back in a way. It helps us learn more about, more genes that can cause seizures and about the genetics of epilepsy, which is very helpful. So, yeah.
Could someone have epilepsy for a long time, not really and then something triggered that gene activate?
Yeah. Oh, these are just really great questions. So, oh, good job, good job. Okay, so someone asked the question, can a person have a genetic epilepsy, but it almost lie dormant or something like that, and then something triggers it to happen? Can that, can something trigger it to happen? So, in a way, yes, but there isn't really something that triggers it. It's more so just our normal human pattern of development. So here's an example I like to use. So there are some genes where we know kids almost always start having seizures who have this diagnosis when they're exactly 6 months old or near exactly 6 months old. People always wonder, like, why didn't it start much earlier in life? If the gene was with them and they're born with it the whole time, why did it start at 6 months? And that's because our genes are important in our bodies at different times of our life. So one way to think of this, the easiest example is like going through puberty or something like that, right? So those genes that make us go through puberty, we're born with them, they're with us our whole lives, but around 9, 10, 11, 12, 13, they turn on all of a sudden. And so all genes work like that. Genes work like that for that type of thing, but also brain genes, eye genes, everything. So there are genes that can become important at a certain time of our life. And then when that gene becomes important, but there's a difference in it, it then causes epilepsy at that time. So less of something that triggers the gene to turn on. It was always going to turn on. It just turned on at a certain time, is the way that I would think about it. I hope, did I get at it? Okay, okay. All right. All right, thanks all. Thank you. Yeah, absolutely. Yeah.
All right, thank you so much. Appreciate it. If you can fill out the evaluations, that would be great. And there's going to be a second poll that's going to be launched on Zoom. It's kind of like what you guys are filling out, just to get an idea of what the best way to present these things from year to year. And I hope I see you all at the walk on June 12th. We're going to have so much fun. Right, Bart?